Assalamu alaikum. Bismillahirrahmanirrahim. The topic of my presentation today is the last few topics from the chapter of Strabismus. Specific learning outcomes. By the end of this presentation, the participants will be able to know about congenital cranial disinnervation syndromes, A and V alphabet patterns, squint surgeries, complications of strabismus surgery, botulinum toxin chemodenervation. Congenital cranial disinnervation syndromes are a group of disorders in which few syndromes are included. They occur as a result of brainstem or cranial nerve developmental disorders. They have an identifiable genetic basis. The syndromes that are included in these are Duane retraction syndrome, MOBIUS syndrome, congenital fibrosis of the extraocular muscles, Strabismus FIXUS, Marcus gun jaw winking syndrome, and Brown syndrome. Brown syndrome can be acquired or congenital. The congenital one is included in this list of syndromes. Firstly, we'll discuss Duane retraction syndrome. There is failure of innervation of the lateral rectus muscle by the sixth nerve. It occurs because there is hypoplastic sixth nerve nucleus. Innervation of lateral rectus then occurs by third nerve fibers. It can be bilateral. They can be associated systemic features like deafness, external ear abnormalities, speech disorders, and skeletal abnormalities. The clinical features of Duane retraction syndrome include face turn, restriction of abduction as a result because the lateral rectus muscle is not functional because of hypoplastic sixth nerve nucleus. Then there is restricted adduction also. There's retraction of the globe on adduction that occurs because of the contraction of medial and lateral recti muscles. An upshoot or downshoot in adduction. This occurs because the lateral rectus muscle, which is tight, it slips over or under the globe and causes upshoots and downshoots. And there is also deficiency of convergence. The Duane retraction syndrome is classified into types. In this picture, Huber type 1 and type 2 are shown. In Huber type 1, there is esotropia in primary position, and in Huber type 2, there is exotropia in primary position. In the first picture, there is in the primary position, there is straight eyes in primary position. Then in B, extremely limited left abduction. And in C, there is narrowing of the left palpebral fissure on adduction. In the second picture, which is showing Duane syndrome type 2, there is slight exotropia in primary position. Then in the second picture, it's limitation of right abduction with widening of the right palpebral fissure. And in C, there is grossly limited right adduction with narrowing of the palpebral fissure. Majority of the patients with Duane retraction syndrome do not need any surgical intervention. The surgery is advised for cosmetically unacceptable head postures, for globe retraction or neck discomfort, and for upshoots and downshoots. The procedure of choice for this includes unilateral or bilateral medial rectus and or lateral rectus muscle recession, transposition of superior or inferior rectus to lateral rectus muscle. Resection of lateral rectus muscle should not be performed. The next syndrome is MOBIUS syndrome. It is a rare sporadic condition. It is congenital non-progressive bilateral 6th and 7th cranial nerve palsy. The clinical features include, in systemic features, there is bilateral facial palsy. 5th, 8th, 10th, and 12th cranial nerves may also be affected. There are limb anomalies and mild mental handicap. The ocular features include bilateral 6th nerve palsy, horizontal gaze palsy, and occasionally 3rd and 4th nerve palsy and ptosis. This is a picture of a child having MOBIUS syndrome. In the left eye, he's unable to close the eye. Then next we have congenital fibrosis of the extraocular muscles. It is a non-progressive autosomal dominant disorder in which there is bilateral ptosis, restrictive external ophthalmoplegia. In primary position, the eye is fixed 10 degrees below the horizontal plane, and typically vertical movements are severely restricted. In congenital fibrosis of the extraocular muscles, it has a mutation in KIF21A gene. This is a picture of a child who has congenital fibrosis of extraocular muscles. There is bilateral ptosis and divergent strabismus. Next we have Strabismus FIXUS. It is a rare condition. It can be convergent or divergent. In convergent, there is fibrous tightening of the medial recti muscles, and in divergent strabismus, there is fibrous tightening of the lateral rectus. The next we have Marcus-Gunn jaw winking syndrome. In this syndrome, a branch of mandibular division of the fifth cranial nerve is misdirected to the levator muscle. Most are unilateral, and 5% of all cases of congenital ptosis are associated with it. Diagnosis, there is going to be retraction of the ptotic lid in conjunction with ipsilateral chewing, sucking on opening the mouth, contralateral jaw movement, jaw protrusion, smiling, swallowing, and clenching of the teeth. Treatment for mild cases, unilateral levator advancement. For moderate cases, unilateral levator disinsertion and ipsilateral brow suspension, bilateral surgery, bilateral levator disinsertion, and bilateral brow suspension. Next is Brown syndrome. In Brown syndrome, there is mechanical restriction of the superior oblique tendon, limited elevation in adduction. The classification is either congenital or acquired. Congenital is idiopathic. In congenital click syndrome, there is impaired movement of superior oblique tendon through the trochlea. Acquired Brown syndrome can occur due to trauma to the trochlea or superior oblique tendon, or it can occur as a result of inflammation of the tendon in rheumatoid arthritis, pansinusitis, or scleritis. The types can be mild, moderate, or severe. In mild, there is limited elevation in adduction only. In moderate, there is limited elevation in adduction and downshoot in adduction. In severe, both these features are present along with hypotropia in primary position, chin up head posture, face turned away from the affected eye. This is a picture of Brown syndrome. There is limited left elevation in adduction and straight eyes in primary position and downshoot in adduction. The treatment for congenital cases is lengthening of the superior oblique tendon. Indications are when there is binocular function not developed, significant primary position hypotropia, unacceptable head posture. In acquired cases, it depends on the cause of disease. Steroids, oral or injection or by injection near the trochlea can be given. Next is alphabet patterns, V pattern. V pattern is significant when the difference between up gaze and down gaze is greater than or equal to 15 prism diopters. Causes for V pattern strabismus include inferior oblique overaction, superior oblique underaction, Brown syndrome, cranial facial anomalies, medial and lateral rectus overaction. In inferior oblique overaction, the eyes are straight in up gaze with marked esodiation in down gaze. In V pattern esotropia, the medial rectus muscle overacts, thereby increasing esotropia in down gaze. And in V pattern exotropia, the lateral rectus muscle overaction is responsible for increased exotropia in up gaze. In this picture, the first one is showing V pattern esotropia and the second three are showing exotropia in V pattern exotropia. Treatment for oblique dysfunction, inferior oblique weakening or superior oblique strengthening surgeries can be performed. For V pattern esotropia, bilateral medial rectus recession is performed, and for V pattern exotropia, lateral rectus recession is performed. A pattern is considered significant if the difference between upgaze and downgaze is greater than or equal to 10 prism diopters, and patients can have difficulty with reading. Causes include superior oblique overaction, inferior oblique underaction, inferior rectus underaction. For treatment, when there is oblique dysfunction, superior oblique posterior tenotomy can be performed, which corrects 20 degrees of A pattern. When total tenotomy is performed, it corrects 50 degrees of A pattern. A pattern esotropia, if present, then we perform bilateral medial rectus recession, and if A pattern exotropia is present, we perform bilateral lateral rectus recession. For surgeries performed for strabismus, the next topic is surgeries that we perform for squint and strabismus. The aim of the surgeries on extraocular muscles include to improve appearance, to restore binocular single vision, to reduce an abnormal head posture, to expand or centralize a field of binocular single vision. Before any surgery is performed for strabismus, it is very important to correct any underlying refractive error or amblyopia. The types of procedures that can be performed are strengthening procedures, weakening procedures, and vector adjustment. The strengthening procedures, we enhance the pull of a muscle. In weakening, we decrease the effective strength of a muscle, and in vector adjustment, we alter the direction of a muscle action. The strengthening procedures include resection, plication, and advancement. In resection, the muscle is shortened to increase the effective pull of the muscle, and it is only suitable for a rectus muscle. For plication or tucking, it has similar effect to a resection, but it has some advantages over resection. It is less traumatic, it does not sacrifice the anterior ciliary vessels, and it can be easily reversed. In advancement of a muscle nearer, it is basically advancement of the muscle nearer to the limbus. It can be used to enhance the action of a previously recessed rectus muscle. For weakening procedures, we have recession, disinsertion, and posterior fixation suture. In recession, we slacken a muscle by moving it away from its insertion. It can be performed on any muscle except the superior oblique. The next is disinsertion or myectomy. We detach a muscle from its insertion without reattachment. Indications: overacting inferior oblique, severely contracted muscle. And then for posterior fixation suture, also called fade-in procedure, we use a non-absorbable suture to suture the muscle belly to the sclera posteriorly. It can be used on medial rectus to reduce convergence in convergence excess esotropia, or in superior rectus to treat DVD. Next, we have transposition. Transposition is relocation of an extraocular muscle to substitute the action of an absent or severely deficient muscle. Indications include sixth nerve palsy, CCDD, for example, Duane syndrome, which we just discussed, alphabet patterns, and monoocular elevation deficit. Complications of strabismus surgery. The complications can be operative or post-operative. The operative include lost or slipped muscle, globe perforation by a misplaced suture, fibrosis involving fat and adjacent extraocular muscles. The post-operative complications can be overactions, underactions, or anterior segment ischemia. Botulinum toxin chemodenervation. It is injection of the botulinum toxin to temporarily paralyze an extraocular muscle. Effect takes several days, can go for maximal for 1 to 2 weeks, And extraocular muscle, the one in which you're injecting the botulinum toxin, their extraocular muscle lengthens while the antagonist muscle contracts. Indications for botulinum toxin injection includes post-operative small angle residual strabismus to correct infantile esotropia, active thyroid ophthalmopathy to determine the risk of post-operative diplopia, to assess the potential for binocular single vision before a surgery, and cosmetically poor deviation. The presentation was the source of the presentation was from Cansty's Clinical Ophthalmology. Thank you.
Okay, well done. Good presentation. You have summarized all the important points. So we will revisit the important points one by one. So first, coming to Duane retraction syndrome, there is sometimes abnormal head posture, face turn, which is cosmetically not acceptable, and upshoot and downshoot. So these problems require surgical treatment. For upshoot and downshoot, the cause is, as she has told, the co-contraction of horizontal recti. Medial and lateral rectus pulls together and the eyeball retracts, and there is narrowing of palpebral fissure. So what is the treatment? Lateral rectus recession with Y splitting. So I have uploaded a video yesterday night in my YouTube channel describing 6 or 7 cases of upshoot and downshoot with the surgical treatment. So what we do is that the lateral rectus, which is very sort of inelastic and is pulling the eyeball, we split it into 2 halves. So upper half and lower half. We recess it about 6 to 8 millimeter and suture the 2 halves of the lateral rectus above and below about 10 millimeter of the normal insertion. So the slipping downwards or upwards is prevented. So you can see the remarkable improvement in the retraction of globe, in the narrowing of palpebral fissure, and in the upshoot and downshoot. All are corrected by this Y splitting of the lateral rectus with recession. So this is about Duane syndrome. Then we have Marcus-Ganjaf winking phenomena. The one eye has ptosis and the ptotic lid winks upward. It goes up when the patient opens the jaw or moves it side to side. Sometimes it is more manifest with opening of the jaw and sometimes it is more manifest with the activation of the lateral pterygoid. So I always do both movements. In every ptosis patient, I ask the patient to open the jaw and close the jaw and move the jaw from side to side. So this movement I do and ask the patient to repeat it. Right? So it drastically changes the management of the ptosis. You see, if jaw winking is absent or very mild, then you can do levator resection if the levator function is good. But if there is marked jaw winking phenomena, you will have to extirpate the levator, you have to remove the levator muscle and do a frontalis sling. So the management changes. Now there is controversy. A few people would say that do bilateral sling operation to produce symmetry. But I have done many such cases and I have always done unilateral uh, and the patient is satisfied. So patient usually do not like that you touch the normal healthy eye, so we avoid that. We only do the operation in affected eyes. Then there was mention of A and V phenomena. So in A and V phenomena, you have to see whether there is oblique overaction or underaction, and how will you know inferior oblique overaction? What is the feature of inferior oblique overaction? Is characteristic feature. Which movement tells you that there is inferior oblique overaction? When you ask the patient to adduct the eye goes up. So this is called, Americans called it over elevation in adduction. Over O elevation E A capital O E A capital and D capital and small d. So Americans call it over elevation in adduction, and Britishers call it hyper elevation in adduction. So if there is inferior oblique or superior oblique dysfunction, then we do surgery to the obliques. But sometimes AV pattern is not associated with oblique dysfunction. So then what we do, for example, V exotropia, the lateral recti are displaced upwards and the medial recti are transposed downwards. So this corrects the V exotropy. But ये याद रखेंगे. So this is the V pattern exotropia. The eyes are divergent when looking up, and they are normal position or less exotropia in the down gaze. So you will displace the lateral recti up and the medial recti downwards. So this will correct the V pattern exotropia. So then there was a mention of transposition of muscles. So what are the two procedures which we do in lateral rectus palsy? Transposition procedures which are done in lateral rectus palsy. Lateral rectus is not contracting whenever the muscle has paralysis, total loss of power, then it cannot do the adduction. For example, in lateral rectus palsy, if the lateral rectus is completely paralyzed, then the eye will be adducted because the lateral rectus cannot abduct it. So in these cases, we do transposition procedures. If the muscle is peritic, the muscle strength is decreased, then we can resect. Well, that will improve the function. But in complete paralysis, we do transposition. And the two procedures for lateral rectus palsy are Hummel-Schiem and Jensen procedure. In Hummel-Schiem procedure, we disinsert the superior and inferior recti and attach on the margin of the lateral rectus muscle. And in the Jensen, we split the lateral rectus and the superior and inferior rectus and attach these parts together with 40 silk. This is available on my YouTube channel, the Jensen procedure and the Hummel-Schiem procedure. And in monocular elevation deficiency, which is called MED or previously called double elevator palsy, what are the options available to us? Knapp procedure and Callahan procedure. So these are like Hummel-Schiem and Jensen procedures. So the superior oblique muscle, it is a treat to see a superior oblique muscle because it's a very shiny, glistening tendon which is attached beneath the superior rectus. We used to do Faden procedure, that is applying the sutures on the lateral rectus 10 millimeter behind the insertion for DVD. But now we only recess the superior rectus 10 to 15 millimeter. We do not do Faden procedure because it was difficult to apply the suture 10 millimeter behind the insertion because there is superior oblique tendon there. We had to pull the superior oblique tendon forwards and then apply the Faden procedure. That was difficult, so we do not do that. The nomenclature in weakening procedures is interesting. So if we remove the insertion of the muscle, this is called disinsertion. When we disinsert, that means we cut the insertion of the muscle. So disinsertion is not like because the muscle can attach again. Similarly, in myotomy, we cut the muscle, the two ends of the muscle can join together and the resection is not successful. So we do myectomy in inferior oblique overaction. We apply artery forceps and remove 5 to 10 millimeter of the muscle so that the two cut ends do not join together. So this is called myectomy. And of course, we have recession and transposition. For example, in inferior oblique overaction, we have anterior transposition, which can be nasal or temporal. So this is a bit details for inferior oblique weakening procedures. When there is DVD along with inferior oblique overaction, we do transposition. If there is only inferior oblique overaction, we will do recession or myectomy. Okay. Any other points, sir?
What is the usual time or age when we should do the skin correction related surgery? What is the usual age or time?
जैसे कॉलेज लाइटली होता है उसमें 1 year से पहले कर सकते हैं and maximum you can go to 2 years.
Right. जनरल रूल ये है कि आपने करना क्या है इसको लव्य से सीखना, ठीक है, तो एज अर्ली एज पॉसिबल। और दूसरी बात ये कि बिफोर गोइंग टू स्कूल, बच्चे जब स्कूल जाते हैं, इफ दे आर हैविंग अ स्क्विंट, दे हैव अ सोशल ब्लेमिश, ठीक है, एक मुख्तलिफ। तो इन ऑल केसेस इफ यू हैव टू ट्रीट
Genital, or we call it infantile, because these present within first 6 months of life. So if there is large deviation, iso or exo, and there is no refractive error, then we would like to do it before 1 year of age, because the fusion binocular vein develops within 1.5 year or 2 years. So if you do the operation before 1.5 or 2 years, there are chances that patient will improve the binocular single vein (BSV), which includes fusion and stereopsis, depth perception. But after 2 years of age, whenever you do the operation, it is cosmetic. So, as Sir has told that best time is before 4 or 5 years of age, so that the patient or the child does not face problems in the school. The friends do not make fun of the patient. But unfortunately, more than half of the patient come as adults. So at that time, after 2 years of age, the surgery is cosmetic, and it can be done whenever the patient feels cosmetically the squint is unacceptable. In every squint case, you have to do two things. Number one is refraction. If the child is less than 7 years of age or the patient is having esotropia or deviation, you do a cycloplegic refraction. You see, even if an adult or a young person comes with esophoria, I will do cyclopentolate refraction to reveal the hypermetropia. Sometimes the patient puts on the glasses and the convergent squint disappears. So refraction is very necessary in every case of squint. In fact, whenever a squint patient comes to us, the next step is asking for VN and refraction, right? And the second thing is we want to do fundoscopy. in every patient, because I have seen a case of lateral rectus palsy bilateral, which was operated for squint, and the patient had a brain tumor. So we don't want to miss the important pathology and just concentrate on the squint. We, if there is acquired squint, we always investigate. If there is diplopia and squint which is acquired, the first thing comes to our mind is myasthenia, because it presents with ptosis and diplopia, and we ask for anti-acetylcholine receptor antibodies in the serum to rule out myasthenia gravis, right? Similarly, in every paralysis, we do force duction test. We move the eye in all the directions and we see whether the limitation of movement is because of palsy or restrictive pathology, like in thyroid or fibrosis or orbital floor fractures. So restrictive and paralytic, these two are differentiated by force duction test. So in every paralysis, we move the eye. Well, if you want to confirm the sphero-oblique laxity, which occurs in sphero-oblique palsy, you move the eye in the direction of that muscle, that is upwards in adduction, and you press the eyeball so that the muscle is lengthened, and see to which extent the eyeball can be rotated. So if the eyeball goes up and you can't see the limber, it means that the superior oblique is lax. You will have to do plication. It's called tuck, superior oblique tuck, or if there is more intorsion, you have to do Hirata-Ito procedure. So we have to see whether there is restriction of movement or not. We usually do in operation theatre. It can be done with anesthetizing the muscle insertions, and you can hold the muscle insertion in OPD also. Usually done with cocaine application, which is not available here. So we do this in operation theatre just before doing the surgery for the squint.
Any question? आप लोग भी question हो?